Well, hello and welcome to the podcast from the Huffines Institute for Sports Medicine and Human Performance. I'm your host, Dr. Tim Lightfoot, and I want to thank you for taking the time to join us today. We're very excited to bring you another guest today to talk to us about the role of exercise and health in the pandemic. As much as we want this to be over, we are still in the midst of a pandemic. And so there's still some things that we can think about and we can continue to put forward on our lives to figure out how to make things go better, maybe how to make us a little bit more immune, and how to live life better. Today we have a guest that we've had on the podcast previously. Today we have Dr. George Cunningham with us. Welcome back to the podcast, George.
Thank you. Thanks for having me.
You're welcome. We are glad to have you back. For those of you longtime listeners, you might be curious to know, Dr. Cunningham was with us on podcast 104 way back in the day when we were only doing audio. That was in 2013, by the way, George. He was with us on podcast 225 in 2017, and now you're going to be with us about podcast 310 in 2021. So every 100 episodes or so, George, we're going to bring you back.
That's right. I look forward to podcast 450 and join you again.
There you go. So let me tell the audience a little bit about why you're here, number one, and give them a reintroduction if they don't remember who you are. Dr. Cunningham is a professor in our Division of Sports Management and Health and Kinesiology here in Texas A&M. But more importantly, he is the Senior Associate Dean of the Graduate and Professional School here at the university. He's also the director for the Center for Sports Management, Research, and Education. Dr. Cunningham is a prolific scholar. He has over 200 scientific articles at this point. He's written 6 books, and he has written 22 different book chapters. So Dr. Cunningham is all over the scholarship and quite well funded as well. He originally has a PhD from The Ohio State. We have to make sure we get the in there for those alumni of Ohio State. He has many awards over his career, including the Diversity Award from the North American Society for Sports Management in 2018. Now, I've asked Dr. Cunningham to come on the show today because he's just recently, matter of fact, last month, had a paper published called Physical Activity and its Relationship with COVID-19 Cases and Deaths, Analysis of U.S. Counties in the Journal of Sport and Health Science. And we will put the direct link to that paper in our show notes, and I would encourage people to read that. And so we're going to talk a little bit about that paper and what new ground it breaks, and it does break some new ground. George, let me start off by talking about saying that, over the past year, we've done several podcasts about how exercise can help immune functioning, can improve immune functioning. So what's different about your analysis?
So from what I could tell, and there's a recent study that was released on Tuesday of this week that supports what we did as well, is that from my read of the research, there's certainly a lot written on the role of exercise in immune responses. And then there's this, and so more of a conceptual argument about, hey, this will be good during a pandemic and, in other situations. There is a separate stream of research showing how physical activity had decreased in many cases during the pandemic, especially during lockdown. Related to that was some research showing that the types of physical activity had changed during the pandemic. So more innovative exercises, more walking in parks when you may not be as susceptible to being around other people, or exercising at home. What I did not see was what, from an empirical assessment of the role of physical activity on COVID cases and deaths. So there was a conceptual argument based on previous research. There was physical activity has gone down, but really the link with using a lot of data from different sources, does physical activity actually matter for your responses to COVID? I hadn't identified that. It doesn't say that it doesn't exist, but I hadn't identified that. And so I think that was a unique contribution, and that the analysis was at the county level, given the data that I had access to. The one that was released Tuesday from Salas and colleagues looked at the individual level and found a lot of the same patterns that I did at the county level. So there's at least 2 studies now showing that this is the case.
Now that was the unique thing about your study, was that it dealt with the community level, as opposed to, so much, and one of the points you make is that so much of the literature is about the individual, and about individuals can maybe change their immune functioning, but you really talked about the community level and how that can affect health.
Yes, and so, part of that is an interest in physical activity at the community level, as you mentioned, that if we think about behaviors and attitudes that whether it's related to physical activity or related to how we interact with others, there's most of the time people focus on individuals, but that necessarily ignores then the role of the community. And whether we talk about the community as like a large organization, or the people in your zip code, or in this case, the people in your county, and that influences health of the community members. And we've done some previous research also related to COVID showing that community level bias is related to COVID deaths and COVID cases. And so if you think about implicit and even explicit racial bias, that's predictive of those COVID related outcomes. So expanding that then to physical activity, that it's really reflective of, from one perspective, a community emphasis on health. And physical activity is one of those components, and a pretty big component, but certainly just one component of how communities, or in this case, counties, think about health and well-being, and support that. Support it through active living, support it through hospitals, through primary care physicians, et cetera. There's a host of elements of that.
So I'd say let's just take a step back. We'll come back to this because you're really about to get to the payoff, the payoff line here. And but I think maybe the audience may be asking, like I did, how did you get this data? Because these are all the counties in the United States. And you got both physical activity data and COVID data. So can you tell the audience a little bit about how that data gathering and generation went on?
Sure. So it's, years ago, these data would have been protected or difficult to access. But thank goodness there's pros and cons of the internet. This is a pro. Data are out there. You just got to know where to find it. So the COVID data is in a host of places. Obviously, like Johns Hopkins is known for a lot of their COVID dashboard and work. And the CDC posts data as well. For a long time, the CDC drew from a website called USA Facts and USA FACTS. And that website provides data across a host of areas, but great data at the county level, day by day, from early January, when the very first case was identified, through today. You could look at, by county, the number of cases and the number of deaths. And there are limitations of the data, so they don't, that I've seen, break it down by categories of demographics. And so you have to look at other sources for that. But for the USA Facts data, looking at the cases and deaths by county, that was super. And that others had used it, points to, okay, these are actual reliable and valid data. And there was another study that looked at, okay, I think there are 3 or 4 sources of county level data, and they are related like at the 0.9996 level. So there are some variations, but what the USA Facts does is web scrape all the county websites. And there's some, I think, staff entry when the websites don't have data that can be scraped, but otherwise it's really just pulling from the state and from the county.
But that's an important point, though. Before you get away from that, especially the COVID data, there has been so much discussion in some places about whether the COVID data is actually accurate or not. I mean, you and I both have heard some of the dissenters out there that basically say there are much fewer deaths from COVID than have been, attributed to that. And so part of our job as scientists is to make sure, as you said, our data is precise and reliable. And can you just say another word about it? Because you talked about how other people had used that data, and so you kind of thought it was reliable. How did you convince yourself that this data was reliable?
And isn't that a good question? I took my daughter to school today, or to swim, and then picked her up, and on the way back, she was talking about sharks eating something that affects the internet that she had read about. I said, well, did you check that source? Because that seems kind of outlandish. And where did you check it? And so just because something's on the internet doesn't mean that it's necessarily the case. And so I wanted to check to see, are these data consistent with what others are saying, and who are using these data? So, that Google used it, I think the Kaiser Foundation used it, and the CDC used these data. Gave me some reassurance. But then there was another study that looked at the Johns Hopkins data, the USA Facts data, and there was either one or two other sources as well that are all public data, and compared them, again, the day-by-day counts. And there are variations, but when you think about, there's 3,000, I think 145 or something like that counties in the US. Across all those counties, across the now probably 390, 400 days that we've been in the pandemic, to have a 0.9996 relationship among them, that's pretty good, I think. So they're all saying the same thing.
But and that's the point. Before we go on, I want people to understand that scientists just don't take this stuff with a grain of salt, that we think about these things. That's one of the boring things about our job. We actually think about data reliability. Can we trust the data?
Yes.
And that's why, when we publish something scientifically, it's not just something we have made up, like is so often on social media. We just don't make this stuff up, that there are reasons why we use the data that we use. And thank you for, I know this is a little bit of a sidelight from where we went, but certainly with the debate around the accuracy of the COVID data, it's nice to hear how you took care of that. And so now you were going to talk about the physical activity data before I got you off rail there.
No, it's good. So the physical activity data is somewhat similar in that it's publicly available, and there's a website called the Healthy Counties ranking, or it's a Robert Wood Johnson supported website, and it ranks all counties in the US based on a host of indices. And a number of people, I usually cite a handful of them, but Hood and colleagues is the one that I think was one of the first ones that provided a scheme to kind of think about, or a classification to think about, how do we think about health at the county level? And how do we weight things? Because if we draw from different data sources, how do we aggregate them and then weight them to, think about, here's, this county is more healthy than this county within this state, and then you can rank states, et cetera. I didn't weight any of the data here, so I used the unweighted data, but they provided physical activity data. And it's not, I think it's good physical activity data. I wish they would have done a little bit something different. And I'll tell you, it's from a national study that's done, and they, again, pulled the data to integrate it into this website. And then you can see they list, here's the source and here's where we got it. So then I click on the source, I go, backwards from there to see, okay, here's the original data, and yes, that lines up. These data were just the number of people who indicated they were active over the past, I believe it was 30 days. So it's not that they met the minimum recommendations. It's just that they were physically active, or that they were sedentary. And that's the measure. And then they have the percent within the county who were physically active. So some reviewers say, well, it's just activity in general. You're not really providing information. Other reviewers say, well, that underestimates things. Think about really the benefits if they would have met the minimum recommendations. I like that perspective. So that resonated a little bit more with me, in that it's the reader decides for the reader self on how to interpret things. What seemed to make sense in going through it and looking at the other research is, what we're saying is that physical activity in general, any level of physical activity, has these benefits and these outcomes. And what they didn't say is the type of physical activity or the amount. And so we need those data. But if anything, if just any physical activity has these benefits, think about if we meet minimum thresholds or minimum recommendations for physical activity. And, from a theoretical perspective, we would expect the benefits to be even greater if you meet those minimum recommendations. So if anything, it's a conservative estimate.
So now, thank you for going off on my tangent with me on the methods. Let's come back to your paper, and you started to kind of refer to what you guys found in your paper. What was your once you got all this data and you did all the analysis, what did you find? What was your take-home message?
So the Healthy Counties website provides a whole host of other data, as I mentioned, related to health at the county level. So we wanted to control for those, and we also drew from some census data and some USA facts data to account for cases and deaths per 100,000. So I mentioned all that because we controlled for a number of things. We thought, this could explain COVID cases, COVID deaths, other than physical activity. So we want to rule out as many possible alternate explanations as possible. So we did that, and then found the original hypotheses were that, the more active a county is, the fewer cases and the fewer deaths. And we found that to be the case. And we controlled for also the state level effects. So, Texas has 254 counties. And it's interesting when you do some of this county data, you see like Arkansas, which has a population about the size of Houston, has a ton of counties. And you think, why do y'all have so many small counties? But so you start to kind of see some of those interesting geographical trends as well. But so we account for the county level and then account for the state level. And even after all that, find that physical activities related to fewer cases, fewer deaths. I think the key thing was, in looking at the data, the correlation between cases and deaths was moderate to high. It was 0.45, which from a social science is moderate to high. That I think from a physical science would be considered quite a bit lower. Either way, that tells you there are other things that are impacting the case to death sort of relationship. So part of the project then was to examine, does physical activity impact that relationship? And it did. And so the more active people were in a county, the weaker the relationship between cases and deaths. And the less active then, the stronger the relationship, which I think is the real meat to it, right? You can certainly have the immune response to where potentially you wouldn't contract the virus. But the key thing is, how does your body react to the virus? And this study showed that there were fewer deaths. The Salas study that was released this week and looked at the individual level and saw that there were fewer hospitalizations, fewer deaths at the individual level for people who met minimum physical activity requirements. So
if you're active, you're less likely to die.
Less likely to die, but also less likely to be have some of these really negative effects. I mean, that's obviously a big negative effect, but the hospitalization, some of the lasting effects, the Salas study would suggest from COVID, but certainly our study showed that, it's, at the county level, deaths and cases per 100,000 residents, that relationship between cases and deaths weakens the more fiscally active those county residents are.
So were there other characteristics that you saw, that you talked about, that 0.45 level of relationship, and that there were some other factors probably playing? What were some of those other characteristics that you saw that may influence the COVID case and death rate?
So that's an interesting question, and one that I can kind of piece together. We didn't necessarily do in this study, but we, in a separate study I did with Lisa Wigfall, who used to be in our department and now is in Houston at one of the medical centers there. And we found that, again, the sort of bias at the county level influenced that relationship, which we said probably pointed to more structural mechanisms, which I think is, when you look at county level data, that's what I would probably point to. So what mechanisms or what structures do you have in place to support health? And to support health for everybody, not just for people with the means. Like, if we get really ill, we're probably not going to go bankrupt. But bankruptcy is a real fear for a whole host of people, depending on the estimates that you read about. It's up to 66% personal bankruptcies are due to medical related reasons. And so, if you're having to make the choice of, do I go to the doctor, or do I, goodness gracious, and do I go to the doctor and have these bills that I can't pay, or do I stick it out at home? That's really not, a good choice to be in, obviously. And or does your county provide? Do you have enough doctors in the county, medical providers? Do you have clinics in the county that everybody can access? That sort of preventative sort of mechanism that can help offset some of these negative effects. I think that's probably what all the collective research is getting to. And this may be a thing for later on in the discussion, but you hope that we're entering a phase where we're seeing the light at the end of the tunnel. But certainly it's not the light at the end of the tunnel for any pandemic. I mean, this is not our first, and it won't be our last. And so, as depressing as that thought is, the good news is that we can do things from a public health standpoint, and from a county governance standpoint, and even a city governance standpoint, to support active living and to support health. And those are things we have control over, which is wonderful. It's just a matter of doing it then.
So we may be wading into some uncertain waters, or some controversial waters, we'll call it that. But didn't you in your paper talk about some of these county level things that can be done, things like asking people to wear a mask and reminding them to physically distance, that were important, you thought, in the results that you were seeing? Yeah,
so that was probably I started thinking about what are health behaviors that are related to, I mentioned physical activity is one that reflects that sort of commitment to health and well-being. What are other factors that are related to, at the county level, that commitment to health and well-being? And one of those is wearing a mask. And as you said, one that probably not everybody is on board with. But that's another area where the data are publicly available. So the New York Times worked with an outside entity to collect data in July. So several weeks in July to see, I believe the question was how frequently, if you're going to be outside and within close to 6 feet to other people, how frequently do you wear a mask? And it was always, frequently, all the way down to never. And so what we found, or what the data showed when I merged those data with the data set I'd already created from all the other sources, was that the physical activity and the mask wearing were somewhat related, and the mask wearing and the COVID cases and deaths were related as well. So it's all, again, kind of working together. And it's all relationship. So I'm not saying that people who don't wear masks don't care about their health and fitness, because you could certainly have a listener saying, well, I'm discounting all of this. What is this guy talking about? But I think the larger point was, and what the data showed, was that if you look at collective health behaviors and collective sort of emphasis on well-being, mask wearing is one of those in this particular time, and that those are related. It doesn't mean that one causes the other. We're talking about relationships here, but they are related to one another. And in a subsequent study that's under review now, and I worked on with Calvin Knight, we looked at what predicts mask wearing, because I was kind of curious then, after finishing this study, about what are other things that predict it. And we found that the sort of social and economic factors at the county level, the individual factors such as do people get their cancer screenings, do they get a flu shot, things like that. All of those are related to the decision as a collective among people in the county to wear a mask. And so, again, kind of going with that perspective that a health and wellness mindset was related to mask wearing.
So, George, this has been another great conversation, and thank you for being with us today. And we're running a little bit short on time here, and as our regular listeners know, and from being on the podcast, we always give our speakers an opportunity to tell us a take-home message. So, as you think about what you would like people to remember from this podcast, what's the one thing, if they remember nothing else, other than the fact that how good looking you and I are, what would you like for them to remember?
I would like for them to remember that any physical activity is better than no physical activity, and that we all have a choice as community residents, as members of a larger community, to support our own physical activity and that of others through the community activities of which we engage. So the more we can, as a group, as a collective, support physical activity and wellness, then the better the collective health outcomes will be.
Excellent. Excellent. So much. Thank you so much, George, for being with us today. And I want to thank all of you that have been listening and watching for being with us today. I urge you to check our other podcasts, especially over the last year, if you're interested in the role of exercise and immune functioning in particular, and how you can exercise during the pandemic. We have covered that in the past, and I would encourage you to look at that. Until our next podcast, though, I urge all of you to stay active and healthy, wear that mask, physically distance, cough into your elbow, and wash your hands. Goodness gracious, those are the easy things to do. And so we look forward to seeing you on the next podcast. And again, please stay active and healthy. And we're out.